think we'll go ahead and get started. Mike Shercliffe, do you want to say something so we can make sure that we can hear you well?
No.
Oh, wait,
don't
sorry,
get him talking.
Anyone?
No.
Okay, so
Whatever you do, don't get him talking.
Nice to be here. Good to see you all.
It's only coming from the computer.
not a worry, then it'll be just fine. Okay, well, welcome everyone to the Central Oregon Health Council meeting. It's great to be in person, and thank you for those that are able to join remotely as well. I think we'll go ahead and get started with, maybe we'll go around the room with introductions if that's all right, because we haven't had a chance to see everyone in a while. For today, and Chair of the Health Council.
Paul Andrews, Superintendent. Welcome.
Yes,
You're here for the first time in
We can barely
3
hear.
years.
They're saying that they can barely hear. So we're
I'm
gonna,
gonna move it a little bit.
we have a little bit of space.
not a worry. This is the part where we make sure everyone.
Yeah, so when you need to be in the middle.
Yeah, I see that. I'm gonna be right there underneath your table.
Yeah, that would be.
Well, my husband and people in my household complain that I have a soft voice. My children never complained about it, but I will reject it anymore. Linda Johnson, Vice Chair of the Health Council.
My name's Fritz Levin. I'm the behavioral health rep on the council and CEO of Best Care Treatment Services. And my wife says I have a hearing problem, and I tell her she has a listening problem. So
We'll flip a coin on who's accurate.
what?
Go me.
Yes. Okay, so how about Carter? Carmen Madrid, Executive Director for Central Oregon Health Council.
Gary Allen, Vice President Clinical Services, Advantage Dental.
Excellent. We'll go ahead and just stay in the room here. So Kat, do you want to go next? Absolutely. Kat Strangelo, Fabulous.
Katie Plum, good afternoon, everyone. Public Health Director in Kirk County.
Hello, everyone in person.
Yay! Tricia Wilder, she, her pronouns, and I'm the CCO Director for Central.
Excellent.
Hi, Tanya Kriel. I'm with the Oregon Health Authority Partner Outreach Program and the Regional Outreach Coordinator.
Excellent. Wonderful to have you with us.
I'm Camille Smith, and I am with Central Oregon Health Council. Kelly Adams with the Central Oregon Health Council. Kayla Urson, Project Manager at Central Oregon Health Council. Pronouns are she, hers.
Hi everyone, Rebecca Berry, she, her, hers, Central Oregon Health Council.
Gwen Jones, she, her, hers.
Excellent. And on the screen, let's start with, how about Renee?
Hi everyone, Renee Worth, Project Manager with Central Oregon Health Council. My pronouns are she, her, and hers.
Excellent. And Marianne?
Hello, everyone. Marianne Wren, she, her, hers, Director of Integration and Community Programs with Advantage Dental.
Wonderful. Mike Shercliffe.
Mike Shercliffe, former president of Advantage Dental, former member of the Central Oregon Health Council, supposed to be retired, representing Redmond Dental Group.
Good to see that your retirement has you back engaged. Dustin Zimmerman.
Hi, everyone. This is Dustin Zimmerman, he, him, his. I am your innovator agent with the Oregon Health Authority. Nice to be back with you following my 2.5-year stint with COVID. So.
It's wonderful to have you. Divya.
Hi, Divya Sharma, Central Oregon IPA and the Pine Community Health Center.
Great. Dan.
Hey everyone, sorry not to be there today. In Portland for work, but good to see you all. Dan Stevens with Pacific Source. If y'all want to really be heard, sit where Gwen is. It's hard to hear most other people, but I know this is the world we live in, so.
Thank you for letting us know. Can you hear me okay if I use this voice?
Not really. I don't know about others, but it's really hard to hear you, Tammy.
I have the same here.
Okay, so how about this voice? This is the one you're familiar with.
Justin, do you want to go next?
Hi, I'm Justin Civil. I'm the Chief Operating Officer for Summit Health.
Excellent. And my screen is, so I think we had Erin on as well, and maybe Andrea.
Good afternoon, everyone. Erin Fair Taylor. I'm the Vice President of Medicaid for Pacific Source, she, her, hers.
Excellent. And Andrea?
Hi, everybody. Andrea Kettlehead, she, her, hers pronouns, and I am the Quality Incentive Measure Program Manager with Pacific Source.
Wonderful. Anyone else that we may have missed? Okay, well, let's go ahead and dive in. First on the agenda.
Hey,
go ahead.
Tammy, no, whatever just happened, you got supremely better from an auditory perspective. So keep it up, keep it up. You don't even have to yell anymore. I just want to give you the good feedback.
I was going for it supremely better. So
Supremely better, yeah. It sounds like we're in a Star Wars movie, but yes, go.
And Dan, you need to clean your room next.
Yes.
We have the mom voice going.
Okay, so consent agenda. I would like to ask that we remove the May financials for further consideration at the next meeting. We have a couple of edits that need to happen. Is there anything else on the consent agenda? I guess that would be accepting the written reports as well as the June board minutes. If the board is pleased with those as presented, then I would welcome a motion or further discussion.
I'll move, carry on.
I'll second.
Okay, we have a motion and a second. Any further discussion? Okay, how about anyone opposed rather than having everyone sort of try to step on each other? So anyone opposed to the consent agenda as presented with the May financials removed? Okay, we will move on to the next agenda item, which is the Healthier Oregon, and I'm going to turn it over to Brad. And I didn't see Brad quite yet on, unless he's joined us. I'm looking around the Hollywood squares, dating myself.
And
Oh.
there's someone who came in.
Oh, hi, sorry, my back eye is shut, so I, please.
Hi,
nice to see
everybody.
you.
I'm Rory Hill. I'm CEO of Central Oregon.
Excellent, wonderful to see you. Okay, thank you. My Addie always thought, she told me one time, Mom, shut your back eye. And she didn't realize in the car that I was actually using the rear view mirror, so. Okay, so we will go ahead and hold off on Brad's update on Healthier Oregon and move on to Operations Council update. So we don't have Emily quite yet, but Andrea, would you care for us to wait, or are you flying solo today?
I can fly solo. That's just fine. Emily was gonna be my wingman, I guess, if I needed anything. So we'll just get going. And if she jumps on and has anything to add, we'll let her add.
That works perfect on our side.
All right, so I am talking specifically about the Quality Incentive Program and providing you all an update, a much better update than what I got to provide this time last year. So let's dive into this. So I want to take a few minutes and update all of you on the 2021 CCO final performance. The OHA just published their final document this morning, so that's exciting. Talk a little bit about where we are for 2022 and what's coming down the pike for 2023. So next slide, please. So for 2021, I want to share with you all what Central Oregon was awarded, and then just kind of high level talk about the two different types of metrics that we had. Next page. So for the Central Oregon, the 2021 performance, Central Oregon did earn a technically greater than a 100% payout. There in the bottom portion, we earned a 108% payout with 15.9 million coming back into the community and back to the CCO for this performance. So, you know, huge amount of work, especially 2021 was, you know, year two. Year two of the pandemic. So huge kudos goes to, you know, all of the healthcare entities, all of our provider partners across the region who really support these members and take care of them and do the really tough work, again, especially during the middle of a pandemic, to perform so well. So yes, huge round of applause. If we go to the next page, I want to dive in. So again, this just kind of recognizes how do we get here? Lots of hard work. But I can say one of the things that the Oregon Health Authority, the Metrics and Scoring Committee, realized in 2021 was, as much as we push, we're nowhere near the healthcare and sector is nowhere near where it was in 2019. So in recognition of that, the metrics and scoring rebased, or they decreased targets on 50% of the metrics starting in 2021. And we see that for 2021 and 2022, which drastically helped. Regardless, we still met them and we still got the money. But this really has played a pretty big role in how we met the metrics and in just some of the glide path that we see through 2022. The other metric that the Oregon Health Authority created in 2021, it was this time last year, was a metric really focused on COVID-19 vaccines for 12-year-olds and older. This is one metric that Central Oregon did not realize the funds on. This metric was, the bar was set pretty high, and it was really ensuring that our communities received this vaccine and received it not only across age groups, but also across race and ethnicity groups. So it was the first time we've really seen a metric dive into race and ethnicities, and we were not at all close in meeting this. So we did leave $2 million on the table in this case, but we did earn back some of those funds through our performance in the quality metrics. So not as huge of an impact, but it was definitely a bummer to see this happen. Thankfully, this is the last year. 2021 was the only time we are going to see this measure. We have not heard any discussions of this measure ever coming back again. So I think that's probably a good thing, but it was kind of a nuance of 2021. And I saw a chat or a question. Oh, yes, any questions? All right, let's jump into 2022 and what's going on for 2022. So again, I want to provide just a little bit of program overview and then a little bit of a status. So for 2022, currently we have 14 quality metrics. 4 of them are kind of at that aggregate level, just very high level, but still meaningful metrics. So thinking kind of about like diabetes, poor control. 3 metrics are pretty new. They're what OHA is calling upstream metrics, and we're going to get into this a little bit more. And then 7 of them are claims-based measures, those measures we've had around for a number of years, childhood immunizations, adolescent immunizations, kind of those standard type metrics. What OHA is calling these upstream metrics, they're fairly new. They're created by OHA. It's not a standard metric that we see nationwide, but they're really focusing on addressing upstream systemic issues. There's a huge drive for cross-sector collaboration. And when I say that, cross-sector outside of the healthcare system, so early learning hubs, all of our community-based organizations, faith-led organizations, really stepping kind of outside of the norm for these metrics. And then the other big change that we see with these metrics are they are multi-year, anywhere from 4 to 5 years, a process metric that turns into a performance metric. So meaning that for the first couple years, we really lay the foundation for these metrics. And then in the final years, we really start getting kind of judged on the performance or the impact that we're making in the foundation, in those foundational years. So if we jump to the next page, this is really hard to see, so my apologies, but This is current state. This is rolling 12 data through 6/30. So next week, we will get data through the end of July. So it's just the timing of the meeting. But you'll see a lot of red in this. However, if you look at the far right column, it's not as daunting as it looks, I guess. So for example, on that dental and oral services metric, ages 1 to 5, we're 0.3 away from flipping this metric to green. So in seeing some of this, knowing some of the trends, I don't have a ton of concern. I think Central Oregon will flip these metrics. You know, historically, we've flipped these metrics. We have a lot of great momentum and effort going on right now. Oops. So I really think we will perform well in 2022. Yeah, there's some metrics that we got to focus on a little bit over the next few months. But again, we also have, you know, it's only middle of August. We have good runway to get this work done yet. So I don't have a ton of concerns for 2022. So that's maybe some good news. Next slide. Also, as part of all this work, and it kind of where does the Health Council tie into all this work? Sure, you know, as the community governance structure and in the way that the CCO is set up, we share a lot of the success. But our Health Council also plays a really important role in what we call the ops work group or the operations work group. Health Council folks, hopefully you agree with my mission here that I created on the fly earlier today, but the mission really is to support the quality program, lift up the metrics, help create and explore and share best practices, and have all the players at the table. It's led currently by Janice Garceau and Emily Salmon. And who are our attendees? Right now, and for many, many years, it's been almost every single one of the PCP groups who care for these members sit at that table. A number of our DCOs sit there, community mental health providers sit at that table. And kind of depending on the topic and the forum, we have a lot of community-based organizations. So it's a very well supported group. They meet on a monthly basis. And without this group, I don't know if we would be in the position we are. This group has been just key in the success of this program and really kind of elevating the efforts around them, around the metrics year over year. So kudos to the Health Council for standing this up. So as we go into 2023, and how as board members can you help support these metrics? I think some of the big opportunities is in these new metrics, these new upstream metrics, because again, this is the first time that the OHA has really kind of realized the strength of the quality program, what it does in moving efforts forward. And so they've created these new metrics with a lot of money tied behind them to start driving some of these bigger changes. And so as you're out in the communities or you're sitting at other committees and you're hearing about social emotional health for kindergartners or social determinants of health, think of these metrics and maybe how we can tie it all together. So next slide. So for the 2023 program, it's our current 14 metric plus one new metric. And this new metric is social determinants of health. This metric is focused on food, housing, and transportation of all the many things that impact health, right? These are the three entities or the three domains that this metric will focus on. It is a 5-year metric. The first 3 years are really about laying this foundation about creating policies, having nationally endorsed screening tools, having a way to collect, if it's a Unitas type platform or another CIE having those types of platforms that will collect this data, those closed loop referrals, making sure that as members are being identified, that we have the adequate resources within the community to refer these members to. It is a huge metric, and it is, it's one that still getting my head wrapped around, but to know that it's really about moving the entire community forward and ensuring that we have adequate resources for these services as we go forward in the future. So that's kind of my last
Hey,
slide.
Andrea.
Yeah, go ahead, Divya.
Andrea, sorry, I have a question. So do you know, or maybe it's too early, are they going to give any kind of, for this big metric, kind of like step-by-step, like needs assessment? Like, here are all the things, are those in place? You know what I mean? Like, so for us to be guided on, okay, where are there areas which we need to now focus on, or we're never going to be successful?
They do and they don't. They tell us in the measure specification to answer yes, you must have done X, Y, and Z. It doesn't necessarily tell you though how you had to do those things. So it lays out kind of a footprint to follow, but it doesn't define it so much as, you know, it's exactly prescriptive. So we get to define it and we get to work through it within the community to what is going to stand us up the best and what's going to work for our community and our CCO and, you know, our greater region. I think each community will probably do it. Each CCO, each regional will probably do it a little bit differently or come up with, you know, different policies, or, you know, if we're going to all agree on using one screening tool, that's going to be different across the state. But for Pacific Source Central Oregon, we get to define it as to what works for us. That's a very roundabout way of saying yes and no.
And so is that just going to be a one metric? Is it, so it's number 15th? So
Yep.
It's one of 15 but probably it's going to be partly a little bit more teeth of challenge pool possibly, or something.
It's not in the challenge pool. They're not weighting these upstream metrics any differently. It's just a lot more foundational work. I don't think it'll impact our PCP groups as much. You know, it's not that they're going to have to do outreach calls to get these patients in. It's going to be, I think, other committees that are going to have to maybe lean in or be stood up to do some of this work. Or maybe it's something that, you know, we couple with the community information exchange type committees and really try to get all the different players on the same page.
Yeah, I mean, it sounds to me like massive infrastructure investment into that whole CIE space, right?
Mm-hmm.
Okay.
And I know there's a lot of work with, you know, Unitas. I think Unitas is going to be a huge component of all this work, even with the social emotional health metric. But that is all stuff that we get to navigate and decide as we go through this. That is one of the neat pieces of these metrics, is they really allow for those foundational years where we are just attesting that we're doing this work. We don't have to necessarily meet performance metrics for a couple of years down the road.
I'd like to
Sorry,
welcome. Whoops, sorry, Divya.
Sorry, I just have so many questions in this space, and maybe I should take this later and talk about it. But
I'd be happy to meet later or even share the specifications with you.
Yeah, no, I think from a process standpoint, it just seems to me like this is going to be something that is potentially going to grow. And maybe this is one right now, but as we think ahead, I think it's going to get bigger. So as I think about kind of where we've set our priorities in the past and kind of being in the place of HIE in the past was its kind of standalone thing, and yes and no, that, it never really, OHA never really put its teeth behind certain areas within it. But it seems like CIE is something that this is becoming its own animal, and just wondering if this would be something from a health council standpoint, a CIE becomes its standalone committee chartered work, because it, does it fall under ops or does it stand on its own? I mean, it's just such different level of, it's like a whole other type of people group expertise. So just putting it out there for the health, and now I'll shut up.
No need to. Those are great comments, and we hear you, and it's noted. I think we do need to look at our committee structure and make sure that the committees that we have today are serving where we're headed in the future and helping us to guide through some of this. So I'd like to welcome Brad, and I also want to turn it over to Linda.
Thanks. I want to just carry on a little further with the direction I think Divya was going. I think we've been really successful with our current structure at engaging community nonprofits and organizations that are dedicated to the same work. But I don't know that I would call that connection with the community, in the sense that if you're not in that nonprofit, you may be married to somebody who works there, but it doesn't spread and translate into community knowledge. And when we're talking about social determinants of health and engaging the community in a meaningful way, that's where the work needs to be done. And so I think maybe we should talk at a future meeting about, so what does it mean when we say community engagement, and what can and should we be doing differently? Because we're not engaging Rotary clubs. They're not a nonprofit dedicated to food security, but they're very interested in the downstream impacts of food insecurity. So that's just one example. Churches are the same way. So I think it's something we've struggled with in the past, is the engagement of the larger community. I think it's a new discussion for us. And I'm really glad to hear what Andrea said.
Excellent, thank you. Rick?
So I think one of the difficulties I think we run into with getting the community involved is these are very detailed discussions deep into the woods. If you're not getting paid to do it, it's incredibly boring and incredibly obscure. And so getting even committed people, dragging you into one of these meetings that we have month after month to try to meet metrics. Oh man, I wouldn't want to wish that on.
Right.
And you, more than any other member of the public, could probably follow. Right.
So it's what information on what topic
And
that
how much.
supports the work of that group, but doesn't invade that group.
Right. Yeah. So, because the Ops Council is way into the weeds, and we need something that's way into the weeds.
So did I understand correctly that Central Oregon will establish their own screening tool for the social determinants of health? Was I understanding that correctly?
Based on the specifications, the Oregon Health Authority has pre-selected, I think there's like 7 different tools that can count. But I think probably one of the big questions is, if 7 different entities are using 7 different tools, how does it flow back to a community information exchange? So we're not rescreening, or what does that look like? And or all the Epic users, because we have a lot of them in Central Oregon, do they all use the same tool, and what does that look like? So I think we have a lot of different pieces to kind of flesh out, and how do we step through this and step through it in a way that it sets us up well for the future.
So I would encourage us to include our community advisory committee as we are picking the tool that will be screening them. It seems like an important voice in making sure that the tool that we choose to use is one that resonates and is not going to create another barrier of concern of maybe the manner in which it's being asked, or maybe it's not specific to our region in a way that's meaningful. But I mean, I would let our community advisory council, folks weigh in on that, but it just comes to mind that that's an important voice into what tool we decide to use.
Very good point. Thank you.
I don't think we want to be assessing 7 tools, but
No.
it would be good to assess whatever tool they're thinking of using.
And I'm not yelling at everyone on purpose. It's they're having a hard time hearing.
They didn't clean their room, and she's getting mom voice coming out.
Okay, so Emily, is there anything that you'd like to add?
I don't think.
Sorry.
Thank you. Thanks so much. Thanks for having me. I don't think so. Really nice presentation, Andrea. And I do want to just give kudos and props to all of your organizations that do participate in the Health Council structure and in the QUIM work group, because that group is engaged. They're sharing ideas. They're learning from one another. And it's been a really fruitful group the last couple of years and a good place of support through the pandemic. So thanks everyone, and congratulations to your organizations.
Thank you. Andrea, anything else to add?
Nope, that was it. Thank you for letting me present and have some of your time.
Okay, well, enjoy the day. You're welcome to stay. Great to see you and great presentation.
Thank you.
So next we will, how about I go ahead and turn it over to Brad? Do you mind taking on Healthier Oregon?
Sure.
Okay.
I just want to keep this in front of everybody, like top of mind, because it's, I'm assuming everyone here is aware of it, but Healthy Oregon was previously called Cover Oregon, passed by legislature to cover undocumented adults who were formerly either covered by only emergency, call-in care, if their life was in danger, there's pregnancy stuff in there too, pregnancy coverage, or totally uninsured, uncovered, unenrolled in college. So it's a huge step forward, but it's also a whole new group of consumers entering the system that our system, I'm not sure, is ready to serve. So just kind of keeping that top of mind and keeping the discussion going and tracking. I reached out to Tricia and asked her, it's very early, right? It started July 1st, really July 11th, I guess. And so it's very early still, so there's no utilization data. Tricia let me know. But they did have, I don't know if Tricia, you want to speak to the call volume from Healthier Oregon program consumers, but apparently it's low, which is not a surprise to me. These are people that don't generally access services. So, Tricia, did you want to say anything?
I'm right behind you. I'm in both places. It's scary. I too have mom.
Explain that to me.
Explain that to me.
The CCO is always watching, Brad.
They're cloning themselves.
Yeah.
When the work's done.
It's their solution to the staffing problems.
Yeah, literally have got your back. I think the only thing I would add in that space, yes, we have seen some call volume increase. We're just as anxious as you are to take a look at the utilization in this space and also suspect some word of mouth within the community. I was able to go, everything went okay, nobody asked me for money. I think that the sharing of that information will also help. So hopefully this will skew up, but the only other thing I would add is that Cover All Kids also rolled into HOP. So it's both adults and children into that space.
Yeah, so I would just add that we have patients with them that are starting to transfer over. Where, it's not super easy to get people in immediately, so there is a capacity issue, I think, to be aware of. and we have some people that are kind of in the middle of treatments and need to be expedited, and I don't know if there's somebody we should be reaching out to other than the receiving offices to help coordinate or prioritize them. Karen,
Let me look into that. I mean, I think going back through CPOP contacts is probably the fastest way to expedite those questions, but certainly I've appreciated both you and Brad reaching out when you have questions. We do have an internal person identified in charge of this, so I often reach out to that person due to our outdated questions. So I can look further into that as well.
I have a question. What's the sort of strategy for folks to find out about this program, that it's happening?
Yeah, I think that's a very fair next. Oh, sorry. Very fair next question. I think that so much focus was initially put on ensuring that members rolled over and that they were the current COW members and Cover All Kids were aware that this process was happening and how did they move, but I think that there is a large opportunity in exactly that. And to take Brad's words he shared once, that hopefully people will come out of the shadows and become part of the healthcare system in that space. And we are preparing some external communication. They're going through our marketing communication process right now. They're almost complete. So as I get those, we'll be sharing those with providers and certainly with Mosaic, DIM, and the LCA to get out and hope that we can start impacting change in that space.
Another piece is that the state has been doing outreach calls to people who are either associated to community partner or not associated, and letting them know about this transition. And then we're working with all of our community partners like LCA and Mosaic and others that are already working with these members we're working with them while they were on CALM and letting them know, hey, we're your community partner, we're here to support you during this transition. These calls are legit, don't be scared. And then helping them through the system navigation piece of this is how you access care, this is how you connect with the provider. So there's a series of calls and outreach being done both state level and then community level. And then maybe Brian can speak more to what LCA is doing.
Yeah, so.
And I want to just do a check-in for those that are not with us in the room. Can you hear this discussion? Okay, so to capture a bit before, so there have been questions essentially around outreach, around capacity, around some specifics in terms of the program being new or its new iteration, and making sure that we have the right engagement and what is the process for access. And there might be some questions that would need to come back to Tricia to fill some questions that were asked by Brad and by Kat. And really just trying to figure out how are we making sure that the outreach is going to meet those that we really need to make sure is able to access. Did I capture that? Okay. Okay. All right. So next, I'm going to go to Brad. Do you want to finish your comment, and then we can go to Gary?
Yeah. Just real quick, just to make you aware, Volunteers in Medicine, Latino Community Association, Mosaic Medical went in together on a combined grant to Oregon Health Authority, and we were awarded for Central Oregon to do this outreach and navigation work. So we are on it, but at the same time hiring.
Excellent. So partnership, Volunteers in Medicine, Latino Community Association, and Mosaic all partnering to be able to get this across the finish line. Okay, wonderful. And what a great partnership. That's awesome. Okay, Gary.
Yeah, just to follow up on something Trish said, when you talked about the call volume, you haven't had a huge uptick. Is that a metric that is being tracked, and how do you account for, maybe I should know the answer to this, but for example, to a contracted entity like a DCO, is that a metric we're supposed to be reporting or tracking?
I would say no. I just reached out because we don't have any hard data to share, just to get our best field data. And, you know, there was, and anecdotally was shared that there is an increase. You don't have to, I don't think, be sure of that. I'm sure our call team, center team manages the metrics there that I'm not clearly aware of in this space, but just that they're experiencing a few more questions in those spaces. So that's a good sign that call volume is increasing around those questions. I don't have any robust data, and then I don't think, I think if any questions were consistently being asked about dental or how that worked, we would certainly reach out and make those connections. I'm confident. I hope that's helpful.
And then just the question of the provider side, like how ready is the provider side to serve this consumer?
Do you want to throw that to the group? So how are we feeling as providers in being able to serve?
Well, I think the whole increase in membership period has made it difficult to serve. So,
Sure.
you know, I don't think this is an overwhelming addition to that membership, but I mean, it's already a problem, so.
So
Bring
go
to
ahead.
PEP, maybe.
Okay.
That could be something that we could bring to PEP and have that conversation with the provider engagement panel, because I think it's not just the volume, it's how they are treated in the clinic and the language access and all of those pieces, right? Is that what? Okay.
So comments from our executive director from Carmen around possible language barriers, being able to make sure that we have the appropriate framework to be able to serve those that we're hoping to serve, and making sure that we are meeting them where they're at, and possibly take this to the provider engagement panel to make sure that we have an opportunity to maybe learn from one another, but also to strategize what that might look like in setting up a plan. Oh, Trish.
Yeah, I would just add to that, the numbers are currently around 300 members in Central Oregon, just to put an idea on that. And again, we're hopeful that that will continue to grow, and that number may not have all of the new kids that are getting enrolled as well too. So this is a very dynamic space right now, but 300 is hopefully helpful in that idea of how many are in that space right now.
And I'm just going to do a check-in, so I'm not reiterating everyone's statements. Can you hear Trisha by chance? Good. Okay. Yay. So I'll stop. Okay. So anything else on that topic?
Just the request to advocate for the coverage of all.
Thank
people.
you.
So there's still a group between 20 and 54 that is uncovered.
Okay.
by OHP.
Got it. And while 300 may sound like a manageable number, that's 300 in our community that haven't been able to have the level of care that we would want to have for every individual in the community. So, it's an important number. So thank you. Okay, so next item on the agenda is the CCO Q2 performance metrics. And I believe, Megan, you are going to tee us up on this. Is that correct? Oh,
Trisha?
Oh, Trisha's taking, that's why I wasn't sure. If Megan, I thought maybe you had comments on it first. Well, Megan, do you have any comment you want to give?
I just can turn it over.
Okay, no worries. So Trisha, go right ahead. Sorry, my bad.
Oh, that's lovely. I think that's the next time I get to present, and I have moved to the big kids table at the front of the room, so I hope y'all can hear me. As you may all recall, we used to have 16 metrics in this space, and just that gigantic confusing sheet that we went through. We narrowed this in Q1, we narrowed this down to 8 metrics that we're going to continue to track. And I'm here to say, while we're only looking at a couple of pages, I have to tell you, we're working on this presentation, and I'm going to pull this out and put it into a PowerPoint so that the text is more readable. So my apologies for the blurriness that you get in a Excel spreadsheet snips. So that will be improved soon. But we'll go ahead and start with quality improvement measures. And I think Andrea really covered this well. When she had up the sheet of paper that showed, you know, she was also apologizing for the blurriness in that space, but the metrics and how close we are and what the numbers are, that her overall comment is that she's not concerned that we will continue, but we must continue to focus and work on and drive this work forward. So I don't want to go through that whole presentation. And again, this is part of your packet. So hopefully you've had a chance to go through that. Andrea, I see you're still on the line. I'd love to give you an opportunity to share anything else in this space that you potentially omitted, or am I capturing your sentiment correct? That while we are lagging a little bit in some of the measures in a rolling 12 space, that you're feeling good about commitments in the work that we're doing with the individual clinics to move these forward?
You captured it. Yeah, we have some measures to watch, but I think in the end we'll get them turned around.
Great. It's going to take a lot of work by a lot of people to continue to do this. So I would just thank the people in the room who have team members who are calling individual members, getting them scheduled so that we can meet these metrics. This work is done on a per member basis by lists that Pacific Source provides to the individual clinic. So our population health team, our quality teams really drive this work with our community partners. So thank you for that. Everything else that we're going to go through is in the green. I'll jump into this next giant box full of statistics to let you know what you don't see in Q1 on this sheet is that the clinical quality team convened a subgroup of subject matter experts to access and analyze results of mental health access to barriers, and then also identify if they can influence any change. So what we're really looking at in this box is data that's being gathered. So you can see of our just over 70,000 members in Central Oregon, 25,000 of those members have a mental health diagnosis. This is probably not a surprise to Rick in the room. The good news below that is we have higher access than the overall CCOs in Oregon. So our mental health access rate in Central Oregon is 63.7 compared to the 57.3, which is our goals across CCOs. So we are higher in access here in Central Oregon. So I know that this can often be a place of challenge in our community, and I think that's worth celebrating. When you break down that 63%, nearly 45% of those are adults, and leaving the remaining 18 and under, which is almost 19% of the access. I'm not going to read the rest of this, but I will tell you it's refreshing for us to see that both the BIPOC community and the Latino, Latinx, Latina, I think I got them, community is accessing at or near the same 63.7%. So that was positive news to find in the data as well. Just a couple of things that are going on. The CCO has developed several collaborations to improve specifically youth access by working with Acute Care Council, Sagefresh Advisory, the Systems of Care, and Oregon Department of Human Services. So we are collaborating with our partners to work and address in this area, as well as working with our partners at Central Oregon Health Council. I'm going to take a breath in just a moment and allow for questions, but there recently was a RIP grant approved in an investment of nearly $500,000 to improve behavioral health providers in marginalized areas. So this is a really exciting grant that was awarded. It takes St. Charles and OHSU and creates a psychiatry residency program. And we have Rebecca in the room. I wonder if you have anything you would like to add to that at all.
I would actually hand it over to Glenn. since
Oh, and we're gonna hand that over to Glenn. You just switched
I
glasses.
know. A few things have changed in the last 2 years.
Just gonna share a little more on the spot, by the way.
The behavioral health work group had a priority area of increasing number of providers in rural areas, marginalized areas specifically. And they actually approved 2 grants. One is the St. Charles Psychiatry Residency Program that's also in partnership with OHSU and building on some pre-existing work. The other one was with the Behavioral Health Consortium around providing the supports needed for interns and associates to be able to provide care while reducing the barriers on existing providers to provide the support that the new providers need. So it's exciting, just recently funded in the last couple of months. So you'll be seeing that rolling out live.
Yeah,
It's exciting stuff.
These are great examples about how we work together in our CCO to really impact change. So thank you. Gwen, I'm sure Rebecca, you helped a little. For your work in this area. Does anyone have any questions on the quality and member experience before I move on to CCO requirements?
And I can't see anyone on the screen, so please just go ahead and shout out your question if you have one. Okay.
All right, rolling on. In our CCO requirements, part of that is we have a goal to reach 60 both certified and trained culturally and linguistically responsive interpreters in Central Oregon. We are in Q2, we've had 8 additional attend the Q2 training. And then just to report back, 20 individuals as of June passed the course. Unfortunately, 6 failed. We are leaning in this space to offer prep for the tests. Unfortunately, not as many people are taking us up on this prep, but we also have some other ideas to help improve that. It's great that 20 passed, but we really want to be supportive and help everyone who takes the course be successful in this space. So does anyone, does anyone have any questions there?
For the ones that failed, do we track what perhaps the problem was?
That's an incredible question. I'll find out what we do in that space because they've already, my broad understanding is there's some time period that needs to wait before you can retest, but I think we absolutely know who these people are. So I'll look into what we're doing with the unsuccessful test takers. Yes.
Are they able to do the testing locally, or are they having to go to Eugene or Portland?
Ooh, such good questions, you two. I'm going to look into both of those. Yeah, where the test takes place and what we're doing with people who aren't successful. Yeah. I'm not going to use the F word. Great.
Old school, sorry.
Yeah, no, that's great. Anyone else?
I would just comment that when we train up Latino counselors, and especially when Spanish is their first language and they've gone to school in another country, the test is the killer. Oh my gosh, and we have to test and retest, and so something about that testing process is really a holdup with otherwise highly competent and intelligent people. So, and of course, testing is a highly cultural experience. And so it's very hard to make test questions that are truly cross-cultural. But anyway, so, and Brad may have more experience with all this than I do, but that's a phenomenon we see routinely.
Is our success rate similar to statewide?
I'll look into that too. But back to Rick's comment that there's no question the test itself is the barrier. I've heard ideas of having some observations substitute for that. So we are working on alternatives to get around that requirement and what that might look like, because there's no question.
Right, and certainly in behavioral health, we've had to go to bat extensively with some folks who were highly skilled, but had the test was the barrier. So.
Great, thank you everybody for your mindful. Oh, sounds like one more.
If you pull together a group to take a look at this, we would be very happy to participate.
Okay, that sounds great. Thank you for that. We'll connect you with the person who is overseeing this work, which is Gretchen Horton Dunbar. Yeah. Great. Well, on to the financials, and this is a big section that, again, I'm not going to read all of this, and my apologies, it doesn't start with 70,000. There was an error in that box. So let me give you the beginning part of that sentence, which is membership as of June 30th was 71,171. So whoever had that number, you win a prize, compared to the budget of 70,963. So as was noted earlier in the conversation, we just continue to grow and grow even beyond what our budgeted expectations are. Currently, we're experiencing a $16.3 million operating gain ahead of what we had budgeted at an $8.3 million. Lots of M's in this conversation. Some of that is a result of a $10 million positive adjustment that came in this year that affects last year's financials. Let's see. I think it's noteworthy to that the new adjusted financials that are taking into account positive adjustments from this year that are going into 2021 are also creating what is shown here as a small shared savings due. I'll tell you what small is to our accountant who provides this language is $700,000. So that's debatable how small that is. So that's where it is currently. And again, the financials will not close for last year until until the end of the month. So we're close to having final on that. And then the most important sentence is the last one, which is the 2022 JMA shared savings is currently estimated to be a future shared savings of $2.5 million. So I'm going to pause there for a moment and see if there's any financial questions, and then ask Megan to lean in as the head of the finance committee.
I think
sounds like we're good.
Yeah, I think you did a great job, but I think it's something to celebrate that we actually are not in a recapture anymore, that we're actually in a positive. So that was really good news at the last finance committee.
Excellent point.
Yes, it's nice. Last year, this time we were in the yellow, so that's very exciting. All right, as we move on to operations, I can really just tell you that the audits that were being completed by our quality review and the health services advisory group are just being reviewed. So next quarter, I hope to report on their findings. And the audits themselves were all on target, so that's good to report. And we do have Q1 2022 look back on grievance and appeals, and we're happy to report that 0% of the appeals in Q1 were responded to untimely. I'd like to rephrase that in a positive, but grievances of 0% of grievances were responded to untimely, and or the flip of that, both appeals and grievances were responded to in a timely manner, as were and then again, 100% of all grievances were timely. So we are on track in that space, and I can't really share how much we value this process and learn how to improve systems, processes, access, partner relations. So this is a really important part of our work. So I'm really proud of our team to have met those metrics. Does anyone have any questions?
Yes.
Yeah, Trish, I'm just curious about the actual outcomes of appeals. Like this, it seems like responses is great to track, but what about the actual outcome? Like the percentage of appeals are actually
So you would like to
in the
see,
consumer's favor. I mean, I know it's nuanced and difficult to talk about in a simple way, but
yeah.
so maybe outcomes in one point.
I'm certain that that's a trackable item that we could look at adding. So you would wonder how many, I just want to be sure I'm getting this right, how many appeals were found to be in favor of the member?
Yeah, I mean, in the outcome, yeah, yes.
Okay.
In the outcomes of the appeals.
Yeah.
Process.
Yeah, I think I can look into that with the group. They keep a tremendous amount of information and look into that. Now, keep in mind, not always found to be in the benefit of the member could be things like somebody was out of network and that necessarily, or we didn't have Pacific Source wasn't contracted with that individual. So it might not necessarily be representative of the full picture if we did that. So maybe there's a, deny.
Yeah, and I think that was really
interesting.
the discussion around setting up that metric is what's the meaning of your answer? And it's not clear. There's a there's a soundbite answer, and then but when you get into it, it's very nuanced. And but the question is, is there a customer service element that you're responding quickly and getting answers to people, whether they like it or not, which was not the traditional thing historically with insurance companies and appeals. So,
Dan, I also see you have unmute.
Right. Rick, you're right. There's process and outcome, right? And the process piece alone is important because it speaks to a level of service or a level of responding. The outcome is pretty nuanced. Another example, and I don't know if this is the top reason for appeal, but it would be one, is appealing a service that was below the line and known to be below the line. And those typically aren't, I would say typically, but that also could be the wrong word, but those often aren't held. So I think what we could do, Brad, is illuminate some more color around appeals and how determinations are made. But I do think if we just looked at, what percent are in favor of the member, I think it would be a black and white picture that probably would beg for more questions. So why don't we look into how we could bring some of that information back in a way that it would just paint a clearer picture, but a full picture.
Yeah, maybe one way to illuminate that would be if you have the data, what types of things are typically appealed? What percentage are my coverage was valid or invalid versus I received bad service from a provider versus some other thing? Maybe just to help us understand who's appealing what, and are there repetitive themes that need to be looked at?
Mm-hmm. I think it's always good to ask too, just from a governance perspective, because sometimes board members can ask questions and we don't clarify what level of people in which room we want this to come to. Is this a board discussion item? Do we want this to go to the CAC? Just clarifying that. Something we want to come to the board.
Sure, with the CAC, I can speak for the CAC. Sure.
Dan, it sounds like it would be important information for the CAC to hear.
Yeah, I think so too.
And as you're eliminating it, I'm guessing, I'm almost certain that you guys would have a quality management system where you're tracking your appeals and what that looks like. And so there hopefully is an existing report that you could share and not have to do extra work.
Yeah, we have a team member, Jessica Waltman, who has done presentations like this in different spaces at the Health Council. So I feel confident that
something off the shelf can be done.
Yeah.
Great.
And then from CAC's perspective, if there's something that needs to come back to the board in terms of that feedback loop, that maybe we need to refine or should be elevated, then I think that would be a good flow. Is that okay?
Perfect.
Great. That's all I have then on the performance metrics. Thank you for your engagement today, everybody.
Thank you. Okay, so now I'll turn it over to Megan, representing the Finance Committee. Megan, did you want to go ahead and open this topic?
Sure, thank you. So there's two topics from the Finance Committee today, and we'll just take them one at a time. And the first one is the quality pool payout. And we talked a little bit about this at the last board meeting. This is actually on our strategic plan. And this initiative actually started a little bit in 2019 with Donna, and then it got put on hold due to the pandemic. And then it's been reactivated through the Finance Committee to look at a way to have more of an incentive methodology for this quality pool payout, similar to what the Gorge has been doing. Donna had been shepherding it with us through the Finance Committee, and now the torch has been passed to Carmen. The Finance Committee tasked a work group to work with the Pacific Source team to come up with a proposal that would go back to the Finance Committee, which has gone back and forth a couple of meetings. I think there's been about 4 work group meetings. They have representatives from Coipa, from St. Charles, from Pacific Source, from Mosaic, and they've been doing some really great work to try and get us to the best approach for us to try this next year, and we'll certainly have a lot of learnings over the next year. So what we want to do today is walk through the recommended methodology from the Finance Committee with this group, and the ask is to consider a vote to approve this methodology to apply to 2022 settlement. Okay, so I am going to hand it over to Tricia.
Great. Thank you so much, Megan. And thank you for highlighting that this is on the Central Oregon Health Council's strategic plan. And thank you to the Finance Committee for the work that they've done in this space. I just want to be sure, as I'm presenting this, that this isn't a Pacific Source led. We are part of this conversation, and I am a voting member on the Finance Council. But also we hold a lot of the data that is really helpful in creating a presentation like this. So thank you for that introduction. That really covers the process that got us to this point where this work was began in 2019, was approved to move forward, but the pandemic really halted all efforts. And then Donna brought this back at the beginning of, well, it might have even been the end of 2021 to reopen this discussion to continue on to the step of quality payout. So next slide, please. So really what the objective in this new methodology is just taking it one step further by further incentivizing the quality pool providers by adding a performance-based step into the formula that we already use. And I also just want to apologize before we get into this because it's a pretty weedy conversation. So thank you for staying with and know that we really spent a lot of time in the weeds in the work group and at the Finance Committee to bring it here. So next slide, please. And again, as Megan stated, here's the work group, and the Finance Committee is putting forth a recommendation to proceed with this methodology that includes the performance-based step as the formula again. Next slide, please. Great. So here it's really a 4-step process. First step, as you may recall when Andrea spoke, so a lot of quality conversation in this meeting today. She shared that just over $15 million, or just shy actually of $16 million, was the total payout of the quality funds. The first step in that is to determine which portion of that goes to the Health Council and which portion goes to Pacific Source. And I want to also be clear that although it is a 50-50 split, Pacific Source does not retain these dollars. It moves through the shared risk arrangement and gets paid out to the community as well. So all of these dollars end up in our community partners' hands. So the second step is to determine, and I want to tell you, we're going to take this verbally and then we're going to do the math in the next slide. So if you have a verbal brain, this part's for you. If you have a math brain, hang in there, we're going to get there. So the second part is to determine provider pool payouts and how much that is per pool. Then it's the performance step is added in. So those first two parts are what we've been doing since 2013. And we did that with the 15 million plus that we received to pay out in 2021. So this is a proposal again for 2022. So it's to run that through how each organization does on each individual metric. It's the spreadsheet itself is incredibly robust, I will share. And when you run it through that third step, there end up being dollars that are unearned. So how do you distribute those unearned dollars is the last step. And that actually took us quite a little bit of time in the work groups to figure out. Megan, do you have anything to add in that space?
That was great.
Okay, great. Let's go on to the math brain people. Next slide. Great. So again, this is just stating that we take the total sum, and you'll see 16 million here, but that's because taxes are included in that amount. So there's a managed care tax of 2% that comes off the top. Then we split the dollars. You'll see that 2 split line, which is third number down. We come out with total payout to the Health Council and Pacific Source of $7.9 million. So there's our starting point in this formula. How are we doing, everybody in the room and on the phone? We good? Yay. All right. Awesome. Let's go from there. Then we establish how much money is in each pool and who is doing the work to get us there. So what you see is the metrics, so adolescent IMSS, assessment for children in DH custody, and we run this through all 14 metrics, but this slide presentation would have been too big for that. So here's what it looks like just looking at those 2 metrics. So we say in the red, the primary care providers do about 95% of that work, but public health leans in a little bit at 5%. And the assessments for DHS, the PCPs do 33%. So we take the total QIMS dollars, we divide them by 14 QIMS. No QIM is worth more than the other, and that's the way it works at OHA. So we follow that model within the Health Council as well. To identify in the box below how much money is possible for each group. So 95% at the PCP takes it to 429,000, and 33% within the PCP group takes you to 149,000 for that, for those 2 metrics. And we run that through all 14 metrics again to come up with how much money is possible in each of those locations. And again, we've been doing this since 2013. So that's the standard step. Next slide will take us to the next level. At that point, you'll see on the far left, those same numbers, 429,000 and 149,000. Now we look at how many members each organization has. So organization X, and we call these denominators. So numerators and denominators is how we work through these metrics within our clinics. So denominator, for anyone not in this space, is really just how the members that are assigned to that organization. So in this case, we look at a total denominator at organization X of, almost 1,200 people. When you run that across that line, it comes up, that's the total denominator, excuse me, across the entire CCO. Then we look at that organization has 201 of those denominators. That's almost 17%, hang in there with me, of the total pool. So their possible payout in that space is $72,000, but they did not meet that metric. So the metric is either met or unmet, and this is the performance part of this process. So now when you look all the way over to the right, you see what that organization's X payout was. So one more time on the line below, 149,000, total denominator in the CCO is 150 people only. 40 of those people are with organization X. That means they have 27% nearly of this metric. So they meet this metric and get nearly $40,000 or the full payout in this space. We could have used rounded numbers. We actually used real organization in this space. That's a bit to take in. How is everybody doing on that? If a metric is met, you get 100% payout, but I think it's really, really important to share, and Megan certainly lean in this space, that we did not want to get ourselves into a negative reinforcing loop
where if I don't meet a metric, I don't have any dollars to work on that metric next year. So the idea of the work group was to ensure that 50% payout would be the minimum if you did not meet that metric, to ensure that there is continued focus and efforts and ability to work within an organization to meet those metrics going forward.
Well said.
So if I don't meet the metric and I get the payout at a reduced amount, where does the remaining go?
Right on, next slide.
Oh,
There's a reason she's the chair.
Okay, all right, just like, wait.
Yeah, well done.
Okay.
So this is a really unique slide to present, but essentially what happens is all the dollars go together. So when we look and we say, here are all the unearned dollars from all the organizations that missed the metric, but you get another chance. So we're going to take each individual organization and their denominators and divide that up for another payment. And, you know, we ran this through that Pachinko machine like 8 times, Megan, right, to ensure that while we did this, we didn't find ourselves back in that net zero position where had I just met the I get the same amount of money either way. So there's still an incentive, which is what this whole new methodology step is for providers to still meet that. And if all of their peers meet the metric, there's not going to be very much money left over to gain back. So it's a really unique situation where we're going to take remaining funds and then we're going to distribute them based on their membership or their denominators in their organizations. And you know, how to do the math on what that will be is really difficult without having those real numbers and that data, but they will not earn more than they would have had they earned 100%. But it still is a way to continue to keep the money within the organizations that are doing this work.
Yes, Michaela.
Justin has his hand up.
Okay, very good. Thank you, Justin. I can't see you, so go right ahead.
Can you see me?
And thank you, Michaela.
Yeah, so the really awesome presentation and great modeling. And I think it makes a lot of sense. It's wonderful to have a, you know, kind of pay for performance metric. I have, I guess, just 2 questions just because I want to make sure I understand it. So for clarity, if an organization had $50,000 worth of funding, but it doesn't meet the metric, that 50,000 goes into a pool, and that pool is redistributed amongst all of the organizations who still carry those attributed lives. So essentially the group won't get its full 50,000, but there'll be some of that distributed back. However, the groups that met the metric will probably see that money. Am I saying that right? Is that a fair?
One part in that. So in that 50,000, 25,000 would still go to that organization as a minimum.
I get it.
So we want to ensure 50% payback on that, and then the other 25,000 would go back through the Pachinko machine and have an award back, but it won't match that $25,000 loss from that organization. Helpful?
Absolutely. And so then just the next one's just a comment. It's not a question as much, but it looks great. And boy, having an enhanced pay for performance is at least what my company has always looked for in terms of lowering the total cost of care. I know you guys have heard that from me a billion times, but is there any possibility as you look at this for this year, for next year, some of these metrics as a group can get floated by groups really beating their target? So ultimately, if we all kind of sink or swim together, one group that gets past the metric by 20% can help make up for another that doesn't make it by 15%. And you know, that's kind of the we're all in the same boat together approach that the Health Council's always used. Is there any potential for offering incentive payments to groups that significantly beat the target? That way we ensure that the population gets the care that we always wanted. You know, they're getting really good quality care, but also kind of we could lean on each other a little bit more that way.
I could answer that, but we discussed this in the finance committee. I'm wondering if Megan, as the chair, would like to lean in this space.
Yeah, I think that was the last finance committee that concept came up. I think that the group for this next year, because of the complexity of administering that and figuring that out, wanted to move forward without that extra incentive. I think there's a couple areas in this approach that we're going to want to monitor to decide if we want to do some edits. There's a couple other areas too, and this could be one we would look at. It would make the Pachinko machine much more complex because you really have to be, there's only so many dollars. And so you have to really be wise about where you're putting them based on, you know, the different metrics. So we also kind of, for this year, we're like, keep it simple because it's a pretty extensive spreadsheet, even in the current construct.
Yeah, it makes a lot of sense. Totally understand. I hope as you all go along, even maybe if the dollars held in the redistributive machine were allowed, you know, maybe that's where the health council or the operations council could have a little discretion to say, hey, you know, this group has already told us they're not going to make it by 200 patients, but there are 2 other groups that can get those 200 patients and help us make it. Maybe we could put some incentive dollars behind it, but I totally understand if you can't do that for this year, and congratulations. It's a really wonderful model. It makes a lot of sense. So thank you for answering my questions.
Yeah, and it's so helpful for these different ideas to come because this will be our first year doing this. And I think, you know, that idea is a great one to be considered and have some of those discretionary dollars for future years. So, and, you know, keep the comments, suggestions coming as we learn through this model.
Yeah, absolutely. Congratulations. It's a really great model. So thank you.
I can clarify an assumption I made that I thought would be part of the answer to Justin's question was, so the example of the $50,000 didn't meet it, got 25,000. The other 25,000 goes back into the pool payout. Everyone gets a piece of that 25, correct? Am I understanding that correctly?
Based on how many members you care for, yes.
Got it. So if I went above and beyond to get us over the line, I actually am getting a little bit more, am I not? Than what I would have gotten just if I got 100%. There is some incentive built into that, am I wrong?
Yes, yes, I hear that, Paul, and thank you for calling that out. This is an incredibly dynamic model. Megan, what are your thoughts in that space?
Well, I think that, like, I think what Justin was getting at is that, yes, there is this distribution with this remaining dollar so that you make sure you get them all paid out, but they go equivalently to all the organizations based on membership. And I think the question is, in future years, do you look at some kind of amount of that money that would be even more incentivizing to organizations that are doing bigger lifts to get over that in some methodology?
Yeah, I agree.
Can I capture that, Justin?
Yeah, absolutely. It's great that we're doing it this way because the intent is, if we believe that the metric is good healthcare, and it's good for the people that we're trying to serve with it, any group that can get even one more person the care that they need, an immunization, a vaccination, whatever, that group should have the option, I think, to, you know, for the financial incentive for doing that extra outreach and beating the target. But also those dollars, if I understand right, they're paid to us based on the entire group meeting a metric. So if we're really short on immunizations for you know, childhood, and my group can't get it done, but COPA can or Mosaic can, is there a way to give them a little extra financial incentive for the extra push they're going to have to make to call those people, to get them in, to track them down? Because if they get it, then the whole community wins. And I think that was so yeah, anything that does that would be great. But even this is a great jumping off point, so.
Okay, Gary.
Yeah, to follow on that same theme, that you'll have to indulge, you had neither a verbal nor a math brain. So going back to number 16 and your example, but it's sort of the same theme. If I'm reading this correctly, for the organization that didn't move, they get 50%. But that would be either met it or you did, black or white. But if we're looking to incentivize a group that might see more members for that particular metric, you know, was there any consideration to a pro rata share? Because this just was like 50%. as opposed to just a 50% share. You know, rather than say, well, I'm not going to make it, so I'm going to give up. I don't know if that makes any sense or not. The question was that.
I think one of the things we were thinking, or at least, I mean, one of the discussion topics was if we kept it at the same, like 1-to-1. So meaning, you know, if you got 30% towards the target, you get 30% of the dollars. If you went 110% of the target, you got 110% based on your attribution. So, you know, if that's possible, then everybody kind of, then the dollars, it's still all from that same pot. It should balance itself out. And everybody who's doing any work and doing any performance based on their lives is getting something if they've done something. And it incentivizes those to go above and beyond. You know, but of course, now if everybody performed 110%, I mean, that would be phenomenal. And the question will be, yeah, do we blow the budget? You know, so I think those are all kind of things, and maybe there needs to be a cap or something, but those were all kind of the ideas that were thrown around, and maybe this group that's doing the math for next year will have that job to figure that out.
So my recommendation is just go with what you've got as an experiment, because my experience with incentive programs is they are dynamic, and there'll be dynamics that get played out in reality that are different than you predict or can predict. And so just continue to run these as experiments and watch how they go. I've been involved in some incentive programs that turned out after a couple of years to bite me in the ass and do exactly the opposite. Or, you know, they're dynamics that are interesting. So I would just say, let's not overthink it. These are all bright ideas. Let's see how it plays for a year, and then reevaluate and build on that. But adding complexity to an already complex model, complex models will have a life of their own. That's my experience.
So that sounds a whole lot like a motion.
I have a motion to adopt the plan as presented by the Finance Committee.
Second.
Okay, we have a motion and a second. Further discussion? Okay, so instead of saying everyone in favor, anyone opposed to moving forward with this as our methodology for 2022? Okay, motion carries, and thank you for the hard work on that. And you know, it sounds like there's some refinement possibly for in the future, but this is a really great place to start. Okay, Megan, would you like to offer some comments on the next topic as well?
Sure. So our next topic is around cost of care. And I think this has been a topic of interest for this Health Council board for quite a while. We've had different approaches trying to understand cost of care and interventions over the years. One example was CUSP, but we haven't found, I think, the pathway that is best helping us. And so I think PacificSource has been working to build out some data and analytics for CCOs around cost of care, and they've been sharing it with different CCOs for the CCOs to observe and decide where they might want to focus. And so it's our turn, and I'm really excited because this is a topic of interest. And we have Carly Hedrick here, who has been excellent at presenting first to our Finance Committee and now to this full board, the areas of cost and opportunity that based on the data analytics that we're seeing in our region's CCO. And then when she's done, I'll talk a little bit about a few next steps. But for today, we really want this group to hear the information, digest the information, ask questions of Carly, and know that we're going to be continuing to work with this data to help us focus on those areas that can really improve those costs. And one thing I think at the Finance Committee that the group wanted to highlight is this is specific to the Medicaid cost of care. And I know that from a Health Council perspective, and many of us, we love to think about the cost of care across all business lines, but today we're focused on the Medicaid line of business. So Carly, I would love to turn it over to you.
Thanks, Megan. Can everyone in the room hear me okay?
We can, Charlie, but before you get kicked off into your presentation,
Yeah.
this is an opportunity for those that maybe don't have as deep of a knowledge in this topic to have a bit of a sort of cost of care 101. And we're going to try not to go too deep into the weeds on it either. But Carly, I do note that your presentation mentions that it's a confidential document. We're in a public setting right now. I just want to make sure that there isn't something that you maybe don't want shared in a public setting, or it's just a notation of caution.
Yeah, thank you for bringing that up. We're okay. There's no PHI or super financial sensitive information. I think our intent with that label was just not to share it outside of the meeting settings to external groups, if that makes sense. Yeah. And can I also do a quick check on our agenda time too? Are we trying to catch up and get finish up at 2:15 still?
You can have a little of my time. I will probably only need a little less than 5 minutes. So you can go ahead and take an extra 10 if you need.
Okay, awesome. Thank you. So as Megan said, my name is Carly Hedrick. I'm an analyst at Pacific Source. We have been working with some other health councils that we work with in Marion and Polk and Lane and the Gorge to present some information. And I would say that we're still really calibrating and making sure we bring the right level of information to the boards and health councils and the finance committees as well. So we're definitely taking and responding to feedback as we go. We did show a longer version of this same presentation to the finance committee a week ago. So this is really more of a high level abbreviated version just to make sure that we're staying within our time allotment. But the Health Council Finance Committee did think that it would be helpful for us to bring to the board as well. And the main agenda or objectives that we had for the presentation is to just start building a grounding and understanding some of the utilization and cost driver patterns that we see for the Central Oregon CCO Medicaid membership. And then also where the data kind of pointed to some potential strategies, we tried to tease that out and pull it out for further consideration and kind of coordination to see if the finance committee or other groups think it's worth moving forward with some actions. And I'll invite others to just jump in with any questions or clarifications. Also feel free to jump in and correct me or state an acronym if I start speaking in acronyms. But we're really staying high level with that grounding of understanding the utilization and cost driver patterns in the region. So what we'll get into at a high level today is our emergency department utilization. But from a high level, we see that costs are lower than Pacific Source Medicaid overall. And our comparison to national benchmarks show that we're in a well-managed range, which is really encouraging to see. For inpatient, we also see lower utilization comparing to Pacific Source Medicaid overall. So we'll get into some of that data. Behavioral health is where we are seeing increasing utilization and costs and also higher utilization than Pacific Source Medicaid overall. That is really resulting in some of the historic deliberate investments that the Health Council and CCO has made to expand behavioral health access to our members. So really we're seeing the results of that in our utilization patterns. And then some of the strategies that we're seeing in the data, the QIM revenue, as Tricia pointed out, there's a really big upward opportunity from our budget assumptions each year to outperform the QIM revenue assumptions. And so that's one of the biggest levers that the group can help kind of achieve for our region. And so we really want to make sure that we're aligning not only for the QIMs that we have, but maybe the QIMs that are coming in future years, making sure that we're really positioning ourselves in a strong place for the performance for quality. And then on the cost side, one of the observations we brought up is ways that we could continue to move upstream from members utilizing the emergency department by kind of better coordinating care for maybe high utilizers in the space or members who have potentially avoidable emergency department utilization. So we'll touch on that. And then we also have a tool that we'll get into called the Milliman Health Waste Calculator. And this is something that Pacific Source has kind of started using in the past couple of years to help us measure low value care. So we'll get into some of the clinical metrics that Milliman has defined to try to measure low value care and show you some potential areas where that spending is happening in our region. I'll pause there for any questions or comments. And if not, one of the things that I like to keep in mind is just a frame of reference is not only how our costs are moving over time, but how that maybe compares with our revenue over time. So what we've done here is take kind of the actual budget expenses in this kind of darker blue line, and these are from our year-end CCO financial reports, and plot that over time since 2018. Obviously, 2022 is not a complete picture yet, but this is our kind of finance performance through June, where we're seeing that we're a lot lower than budget this year. So the budget is kind of the thinner blue line in terms of expenses. But you do see from the history from 2018 to 2021 that our expenses and our revenues are really moving pretty much in parallel for the region, which is kind of showing that, you know, our costs are certainly increasing, but on the other side, the revenue for the most part is increasing and tracking with those additional expenses. And then as you can see for 2022, we're right now in a really favorable financial position where our expenses are a little bit lower than budgeted and our revenues just slightly lower than budgeted. So that's kind of why we you know, Tricia shared the good news that we're in a pretty strong financial performance for 2022. I would say historically, I've seen this gap kind of close as later months develop a little bit more. So I personally am betting that this actual expense is going to get closer to the budget as the year progresses, but that's something we'll continue to watch. I'll keep moving if there's no questions. So we're going to just touch on the revenue side first. So really a big strategic area of influence for the health councils and the finance committee and all the different provider partnerships that we have in the region is the quality incentive metric performance rate. And so typically our budget for the CCO region assumes a 70% quality payout. And what that means is that each year we have an opportunity to really outperform the budgeted assumption to improve the overall financial well-being of the CCO and the Health Council. And so what that looks like in 2022 is essentially an upward opportunity of $2.5 million that's not in the budget through beating our QIM assumptions. And we kind of expect that number, it does change and it varies. It's kind of hard to estimate year to year. But we do expect in future years to still have that same kind of upward opportunity if we really nail it on the QIMs. So not only is it a way to improve the quality of care for our members, but it's also a really good way to improve the financial performance of the Central Oregon CCO Global Budget and the Health Council. So that continues to be a really strong opportunity area in terms of financial performance.
Carly, Justin had a question in the chat. Justin, would you like to speak out that question?
Yeah, just a quick question. A lot of times as we roll through the year, there are charge lags. So paying those lags, you know, paying claims out or keep them do you know, is there any significant like run up in unpaid charges that could create the difference in expense or?
Yeah, so you're talking about the financial slides. See if I can go back to it. Yeah, no worries. Let me grab, oh, there we go. So yeah, I think what we're seeing is as the 2022 develops, like one of the biggest reasons for the current variance to budget is that prior year adjustment that's coming through. Without that, we would be a lot closer to the budget. So I think you're onto something, Justin. There's that kind of year to year changes
Gotcha.
that can impact the current experience. So I think what we are seeing this year is that that's happening on a favorable direction, but in prior years, it's been sometimes I think a slight negative adjustment. I've usually only seen it be in the positive adjustment. Does that answer your question?
Yeah, absolutely. So, and the potential could be as the end of the year, the potential could be the utilization isn't all that different. It's the way that the charging was paid out to jump from 452 to 471. You may have had some things hit last year that maybe didn't come through yet. And so the processing of the charges could be a significant part of what is making the difference there.
Yeah, it's a good call out. I think we were trying to make sure that we're really consistent with the CCO financials for this particular report. We can also report it on an incurred basis, but the CCO financials are all on a paid basis.
Gotcha.
So it's kind of like shifting it a little bit for sure. Yeah.
Okay, thank you very much. I appreciate it.
Yeah. So we'll get into kind of some more of the high level looks at our utilization for the Central Oregon Medicaid membership. This is our first just high level inpatient admissions. And here we're trying to measure it as a measure that we use a lot in healthcare called per thousand members per year, PTMPY. And what we're doing there is we're trying to normalize for all the membership growth we've been seeing over the past few years. Because obviously if we were to just plot raw volumes, we would see everything increasing because our membership's gone up so much. So here we're trying to normalize for that growth in membership by calculating a rate of admits per 1,000 members per year. And what we see is the solid line, which is our rolling 12 months. So it's a lot smoother of a trend to get a signal with. We've seen that really decrease kind of since 2019. And there's multiple drivers at play here. One of them being the pandemic, obviously. So you see each of these circles is actually the month in time. You see a really low utilization in April that starts kind of bringing things down. Members during the pandemic are probably a lot less apt to want to go to the hospital. And also there were some elective procedures canceled. And then the second factor is really that change in Medicaid enrollment process where we are no longer terming members on an automated termination basis. So that means that we're kind of retaining some of that healthier, younger membership typically that might not be utilizing services to the same extent. Those are typically the members who would have auto-termed because they didn't have as much incentive to keep their insurance going if they weren't using services. So overall, that change in enrollment process has kind of a downward pressure on our utilization patterns that we see over time. So we don't really expect the post-pandemic, our newer population to look the same as our 2019, if that makes sense. So a lot of factors at play there, but really the take home is lower inpatient admissions when controlling for membership.
Sorry to ask you a question. I don't want to be the only one jumping in on these things, but it's fascinating to me. In terms of bed days of care, actual bed days of care, utilized bed days of care, is there a way to see this map for that? Because I understand what you're saying, the percentage is changing, but one of the things that would be good for all of us to know is the utilization changing? Like, are the number of Medicaid patients in beds actually going up or going down in terms of bed days of care?
Yeah, Justin, I don't know if I'm translating your metric right. So we have obviously average length of stay for the inpatient admissions, and then we'll have like total days of stay. So is that metric kind of what you were thinking of?
Totally. So if the membership is increased, and it outstrips the rate in which people are in beds because there's only so many beds, it doesn't mean fewer beds were utilized. It just means that this statistic's going down because there are more members, right? Because we're not disenrolling people. Or it could literally mean that the utilization of the beds are down too. And if that's the case, that's a really good thing to know, right? Like it'd be great if actual bed day utilization is down too.
Yeah, that's a good question. I know we have length of stay, which has been increasing slightly for the Central Oregon CCO region over the same time period. But my intuition is that the total bed days would also be on a decreasing trend, but I'd have to pull that up to confirm it.
That'd be great to know, because if it does, then it's not just a function of a cancellation policy. It means we've effectively managed fewer people in those beds, which means the cost should have come down too. So that's awesome. Thank you.
Yeah, and inpatient, I can confirm inpatient costs per member per month are
That'd be
also
great.
going down.
Oh,
Carly, we have-
you know that
We have a
statistic?
question in the room. Sorry, Justin.
Did you say you do know that statistic, that the inpatient spend per member per month is going down?
Yes. Yeah.
Oh, well, that's a confirmer right there. Thank you.
My question is, if we are actually being successful in bringing down and preventing disease through our regional health improvement plan and our upstream prevention efforts in particular, or any of the work groups, is this where it would show up? If so, in other words, if we're better at decreasing heart attacks and stroke, would we not see a commensurate decrease in hospitalization?
Yeah, I would open that up to the floor. I mean, there's a ton of expertise here across the room on what metrics they would look at as well. I would certainly say we would hope to see inpatient admissions go down as we're kind of achieving more of those population health goals, and you know, the members are healthier overall, which would hopefully reduce these inpatient admissions.
And potentially one way to answer your question would be, what's the p-value correlation between the disease burden of being well managed and this? And so if there's a strong correlation, I think you can't confirm causality, but what you're saying, there's already a very strong p-value for, if you manage people's chronic conditions better, there's a lower total spend and a lower total utilization in the hospital. It doesn't mean it's not causal. It doesn't mean you can say it as fact, but so it'd be really interesting to just run a simple p-value on that and find out on those two statistics, how highly correlated are they? When you have 4 years worth of data like that, you can get a really pretty good corollary analysis.
I think Justin's on to some good ideas. I also do think that it would be pretty complex to try to normalize or control for pandemic factors and factors to changes in Medicaid policies. And so I don't know that it would be as fruitful as we would hope it to be for this. And then also, once redeterminations kind of coming back into play at some point, not this year, but in future years, I would expect to start seeing this kind of curve back up potentially. So I wouldn't want to strive for this too hard. I think that there's probably going to be natural upward pressure once those enrollment policies come back, that we're going to start seeing it increase again.
I just do think you could answer it easier because you have 4 years worth of data. So if the corollary factor between 2018 and 2019 is really high, and then when the pandemic kicks in, it's really low, then you'll know there's a lot more at work than just, really well managing the patients. But if you manage their care very well and the p-value stays the same throughout all 4 years, it's again, it's not proof, but it's pretty close to it. The stronger the correlation.
I think I think that is something we should be tracking to get at Linda's point, because evidence indicates, if people's diabetes is well managed, hypertension is well managed, all those things, people are exercising, weight loss, smoking cessation, all of those things. Why we pay attention to it is obviously for better health outcomes. However, those are long term, right? So, and then the pandemic years have kind of messed things up. So figuring it out in a way where even trying to track patients who consistently were able to have their diabetes under better control, what are their health outcomes, and people who, and things like that. So I think it is, that's like, when we can see that is pretty awesome. And to figure out how we track that, but it is year over year. We can't directly say this year it was because of this. It is just a slow, gradual progression.
Yeah, I'll take that back to the analytics team, and we can see what we can move forward with. I'll move us along the slides too. I think there's a lot of information that you guys all will want to see. So here is kind of the first example where we're taking those inpatient admissions per 1,000 members per year, and we're using our Milliman benchmarking data source. And so we're using a vendor called Milliman, who's taking nationally comparable populations and kind of defining these ranges of utilization, with the blue being well-managed utilization range, the yellow being moderately well-managed, and then you start getting into the loosely managed in the red. And so what we've seen again is kind of that decrease in inpatient admissions from year to year, from 2018 to 2022, and really since 2020 falling within the well-managed range in terms of inpatient admissions for our Medicaid members. So this is a comparison against nationally benchmarked data that's really adjusted for different things like morbidity, demographics, regional factors. So they're really kind of trying to get an apples to apples comparison with these ranges. And so far it looks like we're in the well-managed range in this metric.
So Carly, the sort of obvious question is that driven by pandemic chaos or well-managed systems?
Mm-hmm. Yeah, and I think that's going back to what Justin and Divya were talking about earlier too, right? There's multiple factors at play. There's the pandemic, which had a huge impact on everything in healthcare. There's the change in the Medicaid enrollment policies, which is another factor. And then there is also like managed care. So it's hard to get a signal of all those. I don't have an answer for you today, but I think that is a good question.
Yeah, I just want to throw in a caution. I just know my system, there's a whole lot of stuff that's going on that, oh, good luck, oh, bad luck. You know, we don't have control over.
Yeah. Behavioral health utilization side. So I think this is a really big area of interest for our region. And for those of us who've been involved in the CCO pre-pandemic back in 2018 and 2019, will recall the really deliberate investment that we've made to expand behavioral health access to our members, because we felt really strongly it was the right thing to do. And so we do see kind of signals of that utilization really picking up. So if I'm looking at this, the 2019 period, you see kind of a jump up in utilization in the 2020 period, and then staying similar flat through 2021. So we are seeing that investment in behavioral health did bump up the utilization overall of our Medicaid members, indicating that they're using more behavioral health services than they were before. And then on the investment side, that was a significant investment where you do see that peak come up in January 2020. So pretty big increase in terms of the per member per month costs that we're seeing for behavioral health care. And I should also orient the group to the fact that this metric here is really trying to be more of our global definition of behavioral health. And so it's not only including it does include inpatient behavioral health, but that's a small volume. It includes integrated behavioral health in primary care settings. It also includes kind of those panel providers and CMHP, community mental health providers. So it's really trying to get a global look at all the behavioral health utilization in our community.
So the graph there just demonstrating, I'm sorry, just the PMPM on behavioral health went from in the 50s to 76.
Mm-hmm.
Okay, 4-year span.
Mm-hmm.
Cool. Thank you.
Yep. This is kind of another look at what Trisha was presenting earlier. So a pretty encouraging signal here that our access in the region is outperforming Oregon State overall. And so this is the performance improvement project metric that OHA has created where it's trying to measure the members who have a mental health service need, what % of those members actually got care in 2021. And so this is the 2021 baseline metric that they provided for every CCO in this state. You can see that the top two in terms of the highest access rate is Lane at the top and then Central Oregon closely following that. So around 64% of the members who have a diagnosed mental health need in 2021 were able to get a behavioral health service, and that outperforms Oregon State at 57%. So that's, I guess, another confirmation that the investment that the CCO made in behavioral health is starting to see some dividends. And I think that that's what we had planned. We're kind of staying high level for behavioral health, but if there's any questions, I can pause here.
I think you're good.
Okay, if not, we have ED utilization. So this is a really similar kind of look format-wise as the inpatient metric, where we're looking at emergency department visits per 1,000 members per year over time since 2019. And again, a really similar pattern here, right? Where we have here, it's even more drastic, the decrease in the pandemic, where you see April all of a sudden of 2020, almost nobody wanted to go to the ED or was going to the ED. And then since then, our rates have kind of been more volatile than we saw in the history, but kind of our rolling 12 is starting to stabilize, slightly increase for 2022, but overall much lower than the levels we used to see pre-pandemic in 2019. And so far this year, seen pretty stable ED utilization rates. And then here's on the Milliman benchmarking side, kind of how we're shaking out for ED visits per 1,000 member per year and observation care. So for the most part, again, from 2020 onward, seeing that we're falling within the well-managed range, according to the national benchmarks that are, again, risk adjusted and adjusted for geographic factors. So that's an encouraging sign that our ED utilization is falling within kind of an expected to favorable range of utilization.
So, do you know if that's primarily in Bend, or are you seeing similar trends across the 4 EDs in the region?
Yeah, in terms of ED utilization, when I've looked at other CCOs that we have access to in the benchmarking data, I think almost all of them are meeting the well-managed range except for one in Portland. So I think Portland typically is falling in the yellow range and is a little bit higher. Justin, did you have a question as well or a comment?
Yeah, it's so first, this is like the best meeting ever. Just wanted to say thanks because the data actually, it just says, you can't have feelings about it. It just is what it is. So thank you so much.
I have feelings about it, but thank you.
Well, fair enough, but it is what it is. So thank you so much for actually, getting to see some of this. Second, I just wanted to see if I'm restating what the last 3 areas have shown. So through managing the patients better, the use of beds is down, or there's a corollary effect in the spend for beds. Theoretically, at least with behavioral health, we have a better situation than we've ever had in the past in terms of payments and in terms of utilization. So we're doing a better job of offering more outpatient behavioral health services than we have, at least in that 4-year chart. And then with ED utilization, as a community, we've done better at not utilizing the emergency department, which for all of us in the business means we've done a better job of taking care of it at our clinics or in urgent cares or, in other settings, or there hasn't been as much need for it. But universally across the board, all 3 different sets of data are saying pretty much the same thing, that we're doing a much better job of controlling the high cost utilization of care. Is that fair?
Yeah, I mean, I'll let others jump in. I think what you're saying is a really fair interpretation of of the data that we've presented, again, we don't have the strong testing of causality, right? So there's a lot of different factors at play that can drive these trends. But I do think that that's one interpretation of it. Yeah.
And certainly, I'll just lay out I know that there are a bunch of different ways to make a determination on the why, but it cannot be disputed. The utilization is down. I'm sorry, it's up in behavioral health and it's down in beds and it's down in ER.
Yeah, the
Right.
patterns I've been seeing
Okay.
is the utilization for inpatient and in ED are definitely down
Good, that's
from
all.
2019.
We don't need to, yep, thank you very much, appreciate it.
And Justin, I think the noise in the system is that timeline of it going down also correlates with the pandemic start and the redetermination policy changes with Medicaid. So you potentially could be diluting the.
And that was why my question on the bed days was,
Yeah,
is
right.
the actual per member per month total spend down, so that it's not just a function of keeping more members and the same utilization. So if the per member per month spend is down, then also the utilization would have to be down. So it's great, it's data. Finally, it's you know, you can take from it what you will, but it does say something. So thank you very much. I really appreciate it.
Yeah. I'll pick up. Oh, go ahead.
Quick question. So I'm a little slow. So as I see, one of the challenges that we've had is the manner in which people are utilizing the emergency department. And so I see that as a hopeful trend in terms of also possibly getting people in to see their PCP instead of trying to access. Is there a correlation between, or can there be, is there, no?
I mean,
Am I
going back
making
to
it-
what
okay.
Megan was saying,
It's hard to.
tremendous noise in the system, and so the assumptions that we have built in, when you look at it operationally, I'm skeptical of it. So we may be getting lucky because of the pandemic.
Mhm.
And I am thinking another hypothesis is the pandemic is lasting so long and it's still going on. I had more people sick in June than any time yet in my agency. And that it may shape the culture of use of the ED.
That would be, right, so that would be my
You-
hope
you
in
might
terms
get
of getting
lucky.
people into, yes, okay. Because we may have broken a pattern for some.
Right.
I guess
exactly.
it's making it sound not very kind.
Yeah,
But-
Tammy, I would just say, like, don't try to make the data fit the narrative you want.
Yeah, right.
For it
Right.
to have moved that significantly, one way or the other, it means that utilization is down. One way.
Yes, yeah,
One way
okay,
or
awesome.
the other.
Regardless of the causation, it's going in the right direction.
Excellent, okay, next slide.
Yeah.
I just want to say that, given what this council is about and the focus of what we're doing in the community, as well as how hard our providers are working.
Oh my.
We want the payoff, and it's hard to see this and say, well, we can't take credit because it's hard to sustain momentum over time if you can't at some point demonstrate to the community that it's making a difference.
Right, and we want connection for people.
Right.
And if they're finding that in the emergency department, that's probably not the right part of the system. And so that's my hopeful, I'm gonna stay hopeful, Rick, and I'm.
And yeah, I'm highly skeptical that we did it through our hard work and initiative, given that the whole system was in crazy chaos during
Yes,
those
right, yes.
times.
And
But-
I'm not trying to disagree or anything, Rick, but I would just say, given my urgent cares, my primary care shop, I would disagree. We've never seen more patients than we've seen in the last, since the pandemic kicked in. We've never seen more, to the tune of, 1.5 times the number of visits. I mean, I do think we've created access points in the community when there weren't access points in the ER, and it has paid off. I'm not saying that there hasn't been turbulence and it won't go back, but when you start to see data that looks like that, one way or the other, there's been a lot less utilization in the highest cost center. That's what that data says, and that's true. So,
Right,
And I will, sorry, and I will just also echo one more thing. And I think we are not, the shift because of the pandemic to be able to do virtual visits and stuff, and the need for clinics, they just pivoted so fast to be innovative, to reach out to the patients in ways that they weren't before, really made it easy for patients to communicate and connect with PCPs. I do see this from the independent practices. They are just working nonstop, reaching out, working with patients in the outpatient environment. So I don't want to minimize that either. The access points have increased in the outpatient world in ways that they hadn't pre-pandemic.
Can we say that that the pandemic has changed behavior and for all the whole system, including all of us, and we don't know what's permanent and what's not, and ongoing, we'll find that out?
I think it has absolutely shifted how we deliver care. It
Yeah,
has
I would say
absolutely
that.
shifted.
I agree.
Regardless of the causation, I think it has shifted things, created access in the right way, decreased how enticing the ER is. And so just to give a little story, you know, in June, I got super sick with COVID, and I got to a point where, holy moly, if I wait a couple more days, I'm gonna land in the hospital, and I'm able to call and get a virtual appointment, like within a couple of hours, and get prescribed some antivirals that kept me out of the hospital. Okay, that was not possible a few years ago, right? And I would have been sent off to the ER and I so did not want to go to the ER when I was that sick. So that's just a little example, a little story, but I think it's happening a lot, just like what Justin is saying.
Thank you, Carly. We'll turn it back over to you.
Yeah, and this actual next slide connects kind of, I think, to Tammy's points. And what I feel like I should maybe do next and can bring back as a follow-up is like the comparison to history. But we do see for emergency department utilization a really right-tailed phenomenon. And by that, I mean, you know, we have really high utilizers that are driving a bunch of the utilization. And so here we're looking at kind of our membership distribution by the number of ED visits that they had in 2021. And what you see is almost 78.8% of members had no visits to the emergency department in the year. Versus once you get down here to the side where we have 6+ visits, we're less than 1% of our membership had 6+ visits to the emergency department in 2021. But then when you look at the flip side and you look at the percent of the overall ED visits that population is contributing, we're seeing that members who have 6+ ED visits in that 12-month time span were basically contributing about 18% of the overall emergency department visit in terms of volume. So you have a really small segment of your population driving a large proportion of the utilization. And so what we've seen is that that small segment, if we did kind of work, and obviously our region has a rich history of working on managing high utilizers and has a lot of experience to bring to that. If we worked at reducing just their utilization by 25%, it would impact the overall CCO ED utilization by 4.5%. So focusing on that segment could be a way or a potential strategy. And one thing we noticed looking at the data is about 26% of these members with 6+ emergency department visits in 2021 had no primary care visit in that same time span. And I know Rick spoke to some really cool efforts going on in this space for behavioral health resource networks. Hopefully I got that right. Which is one potential factor that could really help our population with this. And I'm sure that there's other efforts going on, but really figuring out as a health council, how do we plug into those efforts? How do we support them? And what else can we do to maybe help that effort? And so I'll land there with this is just a potential strategy, right? If we worked to reduce potentially high ED use for that population and reduced the ED utilization trend by 4.5%, that would equate to essentially a $430,000 in estimated savings.
Yes, Brad has a question.
Carly,
Yep.
do you have any way to tell
Yeah.
how many of those ED visits are related to dental emergencies?
Oh, yeah, that's a good question. It's something that our dental team is actually really monitoring. What I've heard is that that utilization is also down, but I don't have that metric in front of me now.
Like a percent of total is my question, curiosity.
Yeah. And then if there's no other questions, I'll move on to the Milliman waste calculator. I know we're kind of running low on time, so I can try to wrap it up quickly. But we do have a relatively new data source from a vendor, Milliman, to help us kind of measure or potentially put some dollars associated with low value care. And what we see is that in 2021, the Central Oregon CCO spent an estimated at least $1.25 million on potentially low value care for our Medicaid members. And so if we were to adopt some strategies to potentially reduce that by a third, it could achieve $450,000 in an estimated savings for the CCO. And so here's a look at what the top measures are in terms of the Milliman Health Waste Calculator. And then the total allowed waste on the right-hand side blue bar, this is kind of what we're using as the estimated low value care spend there. So the top two measures are a significant portion of the overall wasteful spend. And those for the Central Oregon CCO Medicaid members are right now 2 or more antipsychotic medications concurrently prescribed. That's a medium patient harm measure. And there's quite a few services measured, lower percent of services with waste, according to the measurement, but a high spend on those kind of antipsychotic medication, concurrent antipsychotic medications. And then the second one is, there's a lot of acronyms on that. So it's peripherally inserted central catheters for Medicaid members with stage 3 to 5 chronic kidney disease. And so this is a much rare situation. You can see there's only 13 services, but they're high costs because these members have some bad outcomes when there's peripherally inserted central catheters placed incorrectly. So $162,000 of low value spent. Yeah.
There's a question in the room.
Just a question. If you can define for the group the definition of low value care for those that are not familiar with that term.
Yeah, I think that's a really hard. Wow, I'll pass that out to the group as well. I think what we're trying to do here is estimate some claims spend that we see in our data, where we're determining that that clinical service potentially did not help the health outcomes of a member, and in certain cases could potentially harm the member in addition. And so some of the high level low value care areas of spend might be for imaging that was not really clinically needed. Like in this case, we have peripherally inserted central catheters, which could potentially cause harm and complications to patients with chronic kidney disease. So we're picking that up as low value care because it actually was care delivered to a member that harmed them. Does that help, Carmen?
Thank you.
Yeah.
Okay.
Yeah, there's actually the Oregon Health Authority a couple of years ago released a low value care report for Oregon. And a lot of these measures are similar to the ones that they've included there. So that could be a really good resource that would go more in depth on how they're trying to measure or define low value care. So these are basically the top measures that Milliman Waste Calculator is determining had the highest spend for the Central Oregon region. In some cases, they're high patient harm or medium patient harm, and so these could potentially be areas to look for finding or achieving a savings for the organization or the CCO that would also have a good impact to our members. And so this is just the strategy summary, and then I'll kick it back to Megan to close up. But again, the QUIM performance tends to be a really big strategic area where financial performance can be impacted. And then if we were to work on cost of care savings, some areas that the data pointed to as potential areas for conversation are things like reducing ED utilization via those high utilizing pools or potentially non-emergent care. And then also looking at the low value care via wasteful spending calculator.
Well, thank you, Carly. Like that was amazing. And I know it was a lot to pull this together. So we so appreciate your efforts, and just the way you can present data is really, you're just so talented at it. And I think we're going to spend more time with you and the data. And a couple action items from the Finance Committee. One is Divya is going to take the low value care information to PEP to see if that group sees an area of opportunity we'd want to dive into deeper to have some interventions. And then the QUIM opportunity, we thought aligned very nicely to go to the ops team because they monitor and help support the QUIM work in the community. And then the other ask was if Carly would have the capacity to bring back the similar type of data for other lines of business to see if some of what we're seeing in the Medicaid line of business is replicated in commercial and Medicare lines of business with Pacific Source. And then I think we talked about with the ED opportunity that the frequent utilizers of the ED to look a little bit more into the data to see the overlap of the mental health diagnoses with those high utilizers, and are there some additional interventions, because there's a lot going on in the community. Rick talked about some of the projects he's been working on to help focus on some of these folks to get them into the right place of care. So Tammy, I will pass it back to you because I know we're way over.
Sorry, everyone, but really important information. And, you know, knowledge is key for us to first understand it, to for those of us that are not working in the space every day, but also for us to know where we need to be leaning in on some of the initiatives that could be providing better care, but also lowering our costs in the region too. So thank you, Carly. We look forward to seeing you again. That was really, really well done. And thank you, Megan, and to the Finance Committee for bringing this forward. The next piece on the agenda, I'll be just very brief. I had an opportunity to meet with our small group committee regarding community violence. That was Paul, Katie, Linda, Carmen, Megan, and myself. And I hope I didn't forget anyone. We had an opportunity to meet. There are a number of initiatives happening in the community right now around violence by firearm in particular. That's where this group is focusing in. We have a meeting on Monday, and so that's the update. We're hunting down what's happening in the community right now and want to bring that back to the group. So thank you. That's my update. And next I'll turn it over to Rebecca.
Do we have time? Happy to wait.
Can it wait, or would you?
It absolutely can.
Okay, so we have an update on the community survey. Is that something that the will of the board would be willing that we can give Rebecca her due time in September, or shall we move forward?
September's great.
Okay, so we have a request for September. Rebecca, thank you.
No
Thank you,
problem.
thank you. Okay, so with that, is there anything else to come before the council before we adjourn? Okay, I would just say thank you so much for the gift of time today and the added time, and to the whole team for pulling this together. Really appreciate everyone's hard work, and great to have Carmen here and all of us together. So thank you, and enjoy the rest of the day.